This is Katie Chuba from the Hartland Chamber, and welcome to our COVID-19 vaccine webinar. And I'm just kind of patiently waiting as our attendees filter in. We have quite a few people that are tuning into today's webinar, so we appreciate your patience as we kind of wait for everyone to join us. I don't know if you've ever hosted a webinar, but it's kind of fun to see just the numbers climb and climb.
Right.
It's kind of cool. Maybe we have a lot of people because it's a snow day. I wonder. We did have a few last minute registrations, so it's all good. Well, again, welcome everybody. Again, my name is Katie Chuba. I'm the director at the Hartland Area Chamber of Commerce, and I'm joined today for our COVID vaccine webinar. It's hosted in conjunction with what's called the Livingston County Chamber Alliance, made up of the Hartland Chamber, myself, and the Brighton Area Chamber of Commerce and the Howell Area Chamber of Commerce. So let's start off just by saying hello from my colleagues at the other chambers here in Livingston County. How you doing, Pam?
Pam is doing just fine, and thanks, thanks for all of you being here today, and thank you, Dr. Mougdal and Hannah and Jacqueline for participating with us once again. You've been great partners. And I'd also like to say thank you to Blue Cross Blue Shield Blue Care Network for sponsoring this event. They're a wonderful partner. So thank you for being here.
Thank you for having us, and I just want to apologize for being a minute late. I am jumping from WebEx to WebEx. So we had a systems leadership team meeting with all of the senior leaders, and I just literally left that meeting at a minute early to jump onto this one. So sorry about that.
Yeah, no problem, Dr. Mougdal. We really appreciate you joining us today. I'd like for Janelle, I'm going to kind of turn it over to you. Can you say hello as well?
Yes, thanks, Katie. Hello, everybody. Thank you for joining us and tuning in. We're very excited for the presentation today. And as an alliance, we really work hard to come up with programs that we feel are really going to be beneficial to our members. And we're actually meeting in just a week to come up with some strategic programs down the road. So we are really looking forward to today's presentation and always appreciate the partnership with St. Joseph Mercy Livingston. So thank you so much for being here.
Yeah, thank you, Jacqueline and Hannah, part of the marketing team at St. Joe's. You guys want to say hello?
Good afternoon, everyone. Thanks for having us, and we appreciate the opportunity to share an update and provide the latest information.
Yeah, thank you so much.
Yay, thanks, you guys. Dr. Mougdal, thank you again for joining us. And I agree with Pam. Thank you for your partnership. We're going to run through, I know you have kind of a lot of information to share with us. So I think we'll just jump right to it. If you could start off just introducing yourself and telling us a little bit about yourself. And then I'm going to turn it over to you, and then we're going to hopefully maybe about 15 minutes, I'd say about 12:45, if we could leave some room for some questions. We do, I know Hannah and I probably can facilitate together. We have a document of some questions that came in. Hopefully she shared that with you. I'm not sure. Maybe you have those, heads up, maybe you'll clarify some of those. And then if you do, for those of you that are listening, if you do have a question as we're going through, just go ahead and put it right in the Q&A, and we will really try our hardest to get to those today. If we don't, because we are going to be kind of everyone's time today, we can certainly facilitate through email if you want to have some of your questions answered today. Well, hello, John.
Hello, can you hear me?
Yeah, hi.
Oh, okay, great.
Joining us today.
Yeah, no problem.
You want to say hello real quick and introduce yourself and say hello to everybody?
Yeah, actually, I think I know a lot of folks that at least I can see here, but I'm John O'Malley, president of St. Joe Mercy Livingston, the Brighton Health Center. And you all have a much more important person on here than myself in Dr. Varsha Mougdal, who's, I hope, going to really, I think, tell you what's going on with the vaccine and all the other things regarding the pandemic that you may want to know, or hopefully there'll be a lot of questions for her. She is the expert. She's not only the chief medical officer at both Livingston Hospital and the Brighton Health Center, but she's also an infectious disease physician. So no better person than to talk about what we've been putting up with since, I believe, last February, March, than Varsha. So, I encourage you to think about questions to ask her, and anything and everything is, I think, open for her to address. So, but thanks, Katie.
Yeah, thank you.
I'm glad to have been able to say that, and I'll turn it back over to you.
Well, thank you. Thank you, everyone. Thank you again to the Alliance. And without further ado, Dr. Mougdal, you are on.
Okay, thank you. I appreciate the opportunity to speak with all of you. So as John alluded, I think the rest of my credentials are, chief medical officer, et cetera, are unimportant. I think what matters to this group is that I'm an infectious disease specialist. So this is literally what I live and breathe every day. Did not expect that infectious diseases as a specialty is going to become so popular in our lifetime, but here we are. So I'd like to take us through a discussion on the vaccine, and I'd like to spend a little bit of time on the science behind vaccines. I think a lot of people have had questions about how the vaccine has come to the market so quickly, and concerns about safety, efficacy, and concern about, frankly, politicization of this whole process and whether it's safe for them to use this vaccine or not. So in general, I'm happy to take any questions that anybody has. So I'll take us through this presentation, and at the end, Katie or any one of you, Hannah, if you want to facilitate the questions that are on the page, I can take any that I haven't already answered through my presentation, and we'll be happy to clarify it. So I'm just going to go ahead and start sharing my screen here in a second, and you let me know if you can see this. Can you guys see my screen? Perfect. Okay. I'm going to change that. 1 second here to change it to full screen format, and we can get started with our presentation. So just to give you an idea about the situational update, as of yesterday, the US reached over 27.7 million cases. The good news, and truly a bright spot right now, is that we reached a peak of cases on January 8th. This was the second surge that began in November, and we reached the peak around January 8th. And since then, the number of confirmed new daily cases has fallen by almost 60%. This is true of not just Michigan, but true of the entire country. So it's important, and it's necessary, for us to rejoice in this moment as long as it lasts. This truly sobering statistic in this is that the US deaths surpassed 400,000 on January 20th, and that is about the number of US soldiers that were killed in World War II. As of February 15th, we have had close to 500,000 people pass away from COVID-19. In the US, it's estimated that about 110 million people have had the virus. And this isn't just those that had the symptoms, but also in many cities, including Detroit and even Washington, we had what are known as seroprevalence surveys, where people's blood was collected and to see if they had antibodies, which before the vaccine, to see if this was something that was indicative of whether they'd been exposed or not. So based on all of these surveys put together, that's about the thought that about 110 million people have either had COVID or been exposed to it. This next number is important. 38 million have received at least one vaccine shot, and we're holding our breath and praying for those numbers to climb by the day, which is where we really want to go. So what is the data like in Michigan? Pretty much follows the rest of the country. We've seen a huge decline in the number of cases. We're down to 632. Just to give you guys an idea, we were at over 1,600 to 1,800 cases a day a few weeks ago in January. So this is a substantial decline, as you can all see, that this is, the peak has come down considerably. So this is good news. So switching right over into this particular slide that I like to spend a little bit of time on each of my talks is one of the biggest questions I get, socially, and everybody who knows I'm an infectious disease specialist is, Varsha, every other vaccine that we've ever taken has required about 4 to 5 years before it's ready for prime time, ready for, hitting the market. This one's on the market in 9 months. Should I be concerned? Was the science rushed? Is this something that I should be afraid of putting into my body? Should I wait to see what happens to other people before I do that? And so I want to walk you all through this because I think it's really important that you all as leaders hear this so you can spread this message to your community. So this little pictorial representation shows us the stages of vaccine development. And this first step right here is the basic research step before the trials for vaccine development begin. And typically that step itself takes a couple of years before a vaccine candidate is identified, animal studies are done, some preliminary work on people are done, and it's looked to be, at least in the lab, effective, and then translational science takes it over to the next step. So the interesting and important thing for us all to remember is that the 2 types of vaccines that are now coming out are the mRNA vaccines, which is the Pfizer, BioNTech, and Moderna, and the adenovirus vaccines, which is the Johnson & Johnson and the AstraZeneca and other candidates similarly. All of that has been well researched in the arena of basic sciences multiple years before now. So adenovirus we've really used for quite a while. Now the mRNA is the new vaccine. It's a new kid on the block, but not so new. It's been known in the field of science for over 5 years, where it's been researched for application in cancer vaccines, and it's been looked at and studied quite extensively. And in fact, in the infectious disease world, it's pretty well known that this is the future of vaccines. At some point, all of our childhood vaccinations and everything will transition to the mRNA vaccine, and that's where the future of science is headed. So this part was already pre-done. So we haven't really cut any corners on this. This was already existent before we went into this. In fact, Pfizer partnered with BioNTech because BioNTech was heavily involved in mRNA vaccine research prior to COVID even being on the scene. So the phase 1, which is the safety phase, where they just give it to a few healthy volunteers and make sure that it's okay, as well as a phase 2 where they give it up to 1,000 or so people to find what dose is the most effective dose for antibody production. They're pretty quick in any vaccine trial, and those were quick, just like they normally are. Phase 3 is the one that actually takes the most amount of time in any vaccine trial. And in a phase 3 trial, typically you need to enroll anywhere from 30 to 50,000 individuals. And remember, these are people that have to be enrolled, and they may be people that are exposed or at risk of being exposed to a disease, but they're also healthy individuals. And it takes a long time to enroll people like that. Now, throw into the mix a pandemic that is occurring, and everybody lining up to be part of anything, even a trial, if it gives them a shot of being safe. And you have where Pfizer enrolled 44,000 individuals and Moderna enrolled 30,000 individuals in a few weeks. So you cut down months of time there in just a few weeks. After that data is collected, typically the companies wait for about 6 months after the end of the last dose being administered, the second dose in most of these cases, and then they submit data to the FDA for review, and then the FDA takes a while to review that data. In this case, what they did was, because this is a pandemic and because all the governments, the FDA and everything, these bodies, these regulatory bodies have been in on vaccine development from day one, they have been reviewing data all along. Phase 1, phase 2, phase 3. So they've been getting data on a real-time basis, which is not normally done. So just so you understand that when they approve a vaccine in 2 days, it doesn't mean that they saw the data and in 2 days said, oh, this is perfectly safe for the vast majority of the population. They've been reviewing it the entire multiple months along the way, which normally they would have taken several months in addition, but they've already had a head start on review so that they can look at the data and approve it in a couple of days. The other thing is normally the FDA gives full approval 6 months after this final dose of the final participant has been given. But because this is an extreme circumstance, they took the data 2 months after the final dose to the final participant has been given, and then went ahead to approve it with what's known as an EUA, or an emergency use authorization. And this will convert to a final full approval once the 6-month data is available, and that's pretty soon right now. So we cut a lot of time in that. And similarly, the ACIP, same thing, again, approved it in a day. So, multiple months were cut here, multiple months were cut here as well. But then the biggest piece of this whole thing is vaccine production. So normally, after the phase 3 has shown promise, then the companies have to head out, find venture capitalists, people that are willing to expend the money, and companies that are willing to expend the money. Typically, the smaller firms are bought over by, the intellectual property rights are bought over by the larger firms. And then once FDA and ACIP give permission, then vaccine production starts, and then it's made, etc. This takes probably some years. Now, here you go, where you have every major government in the world saying, here you go, here's billions of dollars for you to start producing vaccine, because we believe that the science is going to show that this is efficacious, and we don't want to be behind the 8 ball when that happens. So you have companies that before they hit phase 1 and 2 started producing vaccines by the millions. So that is how that entire red tape has been cut in a way that the world has never seen before. And multiple years were shaved off by cutting that red tape, because the governments made it pretty much fiscally safe for the companies to produce the vaccines in mass production before the trials were even through, right? And that just never happens. And so when the trials were through, much to everybody's delight, the mRNA vaccine showed 95% efficacy, which was far beyond anybody's imagination. No one thought it would show 95% efficacy. To give you an idea, in different years, the flu vaccine efficacy ranges from 45 to 65%. So that gives you a ballpark of, what we were expecting, that anything that's 70% is awesome. And here we have something 95%. And then the day it gets approved, there's already millions of doses sitting at the different health departments across the country. And within 3 or 4 days after ACIP approval, we received vaccine in Varsha County on December 17th. And that was a Pfizer vaccine. And Moderna followed literally a week after, and we received first Moderna vaccine at Livingston Hospital on December 23rd. So that tells you how that 9-month period was accomplished. But the most important part that I think I'd like you all to individually take to your friends and colleagues out there is that no part of the science was compromised. This entire portion was done just as is. And each of these phases were done just as they would be. And the FDA approval and the ACIP approval were done just as they were. It's just that every piece of red tape that could be cut was cut. And so that's why we're here, fortunately for us, that everything worked out. So how does the COVID vaccine work? And this little picture is a COVID virus. And you can see these little red guys on the surface of the COVID virus. And those little protrusions are what we call spike proteins. So basically, the vaccine makes you make antibodies against these guys, the spike protein. And if your body sees that COVID virus entering, the antibodies that you have will attach to the spike protein and kill the virus, and thereby you don't get infected. So that's kind of how it all works. So what is specific about mRNA vaccines? So the little spike proteins, the little red guys that you saw, they are pieces of protein, right? And in our bodies, messenger RNA is the type of is a genetic sequence that actually codes for a protein. So this little piece of mRNA that's in the vaccine is the exact genetic code. It's sort of like a little recipe book is what it is, exactly, to kind of tell you what it is. It's a recipe book that says add 1 teaspoon of this, 1 teaspoon of this, 1 teaspoon of this, and you get this particular thing out. So that's what this mRNA is. And the mRNA actually, once you receive the injection, it enters your body. The mRNA enters into your own body's muscle cells, and your cells start reading the mRNA much like you would read a recipe, and it starts adding protein pieces one to the other and makes a piece of spike protein. So your own body cells make the spike protein, and when the spike protein is made, the rest, your immune system in your body goes, wait a second, there's an intruder. We need to recognize this and we need to shut this down. And the different levels of immunity engage to find the correct antibody that's going to shut this down. So it goes into training and it detects the perfect antibody to kill that spike cell. And with that, your body is now ready. So the next time it sees a spike protein, it doesn't have to go through the whole process. It's already been trained. It knows exactly which antibody is best, and it makes those antibodies quickly and is able to prevent disease. So that's the way in which the vaccine works. Now, there's a couple of different ways, and people have concerns. This is genetic material. Is this going to get into my genes? Is this going to do something to my genetic makeup? Is this going to somehow interfere? It does not. It doesn't interact with our DNA. It doesn't integrate into our DNA. And actually, about 6 hours after it enters your body, it's dead. It's fragmented and in pieces, and it doesn't have any long-term lasting impact. The cell breaks down and gets rid of it. So it's not something that's there to stay. So what are the common side effects of the vaccine? The side effects of the vaccine pretty much are seen in those that are younger than 50, 55 years of age. And we've seen, I mean, even at St. Joe's alone, between Ann Arbor and Livingston, we've vaccinated over 20,000 people. So even in our little small numbers of that, we know that the vaccines are very self-limited and last for 24, 36 hours. I can speak for myself, and I know that several of my colleagues on this call have been vaccinated as well. The common side effects are what's listed: fatigue, joint ache, low-grade fevers, headache, just feeling tired, and some arm pain at the site of vaccination. And in fact, with the second dose, those symptoms do get magnified. But again, it's a matter of perspective. It's nothing to fear. It's sort of, if you start training aggressively with a weightlifting program, you're going to feel sore for 24 to 48 hours before your body regenerates itself. But it doesn't mean that you're sick or that you have COVID. There is no way that this vaccine can give you COVID because it only has mRNA that codes for the spike protein. So I just want to allay people's concern. A lot of people are concerned that can a vaccine give you a disease? In fact, for the flu vaccine, that's the first thing I hear, is that the flu vaccine gave me the flu. It is incapable of giving you the flu, and much as the COVID vaccine is incapable of giving you COVID because it doesn't have the virus to give you COVID. But even so, some of these symptoms are the same because it's your body kind of prepping for response. And that's what happens when you get the disease. Your body preps to fight the disease. It's just that it's ineffective in that case in some people, which is what leads to severe disease, and okay disease in others. But in this case, after 24 to 36 hours, it just gets rid of the spike protein and it knows what's what, and it stops reacting and you go back to feeling normal. So what's the difference between Pfizer and Moderna? They're both mRNA vaccines. No real significant difference other than the way in which the mRNA is stabilized in the vaccine. So what do I mean by that? The process of how the vaccine is made makes it be either a little bit more tolerant to higher temperatures or not. The Moderna vaccine is a little bit more tolerant to higher temperatures, so it can actually be stored in a regular refrigerator freezer without breaking down. And it actually is given 4 weeks apart. The Pfizer vaccine is a little bit more finicky in that regard, that it needs to be in a -70 freezer. And for that reason, storage of this vaccine is a little tricky. And most hospitals and central hubs have those kind of freezers that we have the availability to store this in. And the Pfizer vaccine is given 3 weeks apart in 2 doses. But if you look at this efficacy portion, they're both about 95% efficacious. So no real difference there. And I just want to tell you that in the world of vaccines, these guys are superstars. We rarely have seen anything like it. Just to put it in perspective for you, what we would consider a nice, happy, efficacious vaccine is something over 60%. So this 95% is not something that we even could have dreamt of. And we're thrilled in the infectious disease world that the vaccine has an efficacy like this. Also, I know that a lot of people are concerned about, the anaphylaxis, allergic reactions that people have had to the vaccine. And I just want to put this in perspective. If you look at this, per million doses of the Pfizer-BioNTech, 5 people had allergic reactions that required an EpiPen or epinephrine in hospitalization, and 2.8 per million of Moderna required it. And in fact, there's updated numbers that show it's even lower. So I know that the press makes a lot of it, and I get people saying, I have an egg allergy, I have shellfish allergy, I have penicillin allergy, I'm allergic to bee stings, I carry an EpiPen, is this safe for me to take? And the answer to that question is yes. None of those matter because there is a compound called polyethylene glycol that's present in the vaccine to stabilize it. It's present in many other vaccines and in many other intravenous products that are administered in the hospitals. So if you've ever had an anaphylactic reaction to another vaccine or to a medicine that you've received intravenously, then perhaps that is something to be a little bit concerned about and is something you should speak to your physician about before receiving the vaccine. But short of that, anaphylaxis to pretty much anything else, shellfish, eggs, bee stings, penicillin, none of that matters. It's not the same compound and it doesn't cross-react. So you can be monitored a little bit longer if you have, everybody's kept for at least 15 minutes after, and those that have history of significant allergies are kept for 30 minutes. But honestly, there really haven't been much of this to, in terms of concern. Next question, once vaccinated, how long until I'm immune and can I stop wearing my mask? So that is an important question and one that we're getting a lot more answers on now. So remember that after the vaccines are either 3 or 4 weeks apart, as I shared with you. And we know now that after the first vaccine, your chance of getting immune to COVID is about 50% only 2 weeks after the first vaccine. That 95% number that I shared with you only happens 2 weeks after the second vaccine. So yes, you definitely need to continue masking, but also we've learned now that the vaccine may not necessarily stop you from being an asymptomatic carrier. What does that mean? It means that if you've been exposed to someone with COVID, you can carry COVID and breathe it out, etc. But you may not have the symptoms because your body is immune and is able to keep it at bay. But that doesn't stop you from spreading it to your loved ones. So for example, myself, I am an infectious disease specialist. I am in rooms with patients with COVID for periods of time because I have to examine them and help them and treat them. I was among the first people in the country to be vaccinated for that exact reason because I am one of your highest risk healthcare workers. That being said, even after my vaccination, I follow every protocol of masking, hand hygiene, social distancing. I'm extraordinarily careful because I don't want to acquire COVID that I myself may not suffer from, but bring it home to my family that has not yet been vaccinated and spread it to my loved ones. So I think it's critical that as a community we recognize that just being vaccinated doesn't mean that you can stop masking and stop doing all of the other things. The other piece of information that we all have to have, and I'm going to speak about this in the new variants, is that the new COVID variants are definitely much more infectious. The UK variant, as far as we know, is well covered by these vaccines. But the South African variant and some other variants that aren't widespread yet in the United States, but could be because global travel is a reality, the vaccine only has 50% efficacy against some of those. So when you don't know if other variants are spreading, you could still again be infected and not know it. So for all of these reasons, societally as a whole, and also individually for your own family and loved ones, it is critical to not let up on masking, social distancing, and hand hygiene even after you've been vaccinated. So you could say then, what does this do? Well, one of the things that the CDC said is if you've been vaccinated and it's been over 2 weeks since your vaccine and you're still within 3 months after you've been vaccinated. So remember, you've received both doses. It's 2 weeks after your second dose and it's within 3 months of your second dose. Then if you've had a high risk exposure to someone, you don't need to quarantine because you're not likely to get disease yourself. But you still need to mask and you still need to do hand hygiene and you still need to social distance. So it pains me to share with you all that masking and hand hygiene and social distance and change of life to some extent, as we've all seen it, is going to be here to stay for at least another year or two until we get our heads wrapped around this process. But that being said, it doesn't mean that we couldn't slowly return to other activities that we haven't been able to do thus far. This is going to help us do that. As teachers get vaccinated, our kids getting back to school, us being able to do some of the other activities that we haven't been able to do, I think it is definitely going to give us some leeway as a society to return to more normalcy, but 100% normalcy isn't here yet. The Johnson & Johnson vaccine is a different type of vaccine. It's a virus called adenovirus, and it's been inactivated. And inside that, it keeps a piece of the DNA that codes for the mRNA that then codes for the spike protein. So it's a couple stages of, the protein development ahead of the mRNA. So the mRNA is just the mRNA. This is inside that little virus piece is where you see that DNA, and DNA in and of itself is much more robust, so it can stand lower temperatures, higher temperatures. And so it's easier to store, and it can store in the refrigerator for up to 3 months. So that's the simple, it's much simpler. And in many portions of the world, as well as many portions of the US, it's easier to store it and administer it. And this is a single dose vaccine. The phase 3 trial data that was reported on January 29th showed that it's about 72% effective in preventing moderate to severe COVID-19 and 85% effective in preventing severe disease. Now, you can compare this to the 95% and say, oh, geez, wow, 95% is so much better than the 72 and 85% numbers that are being quoted that this is an ineffective vaccine. Now, remember what I told you, above 60% is really considered highly effective. So this is effective. It may not be quite the mRNA superstar, but when you think of certain populations, you can see where this might have a niche. So number one, it's going to add one more vaccine that we can give effectively to people in places where the communities where people are hard to reach, socially vulnerable communities that don't have transportation or access, homeless shelters, foster care where there's kind of quick transfers and people are not, always there for long term, where you can't, have a captive audience when people come in and out of homeless shelters. Being able to give a single dose of a vaccine that can give up to 85% efficacy against severe disease is huge societally. So this vaccine is going to have an important place in our vaccine armamentarium. It's going up for review with the FDA on February 26th, and the anticipation is that it will be approved a day or so later, and will be available in the US, ready to go the first week of March. AstraZeneca, I'm not going to go through it, but it's the same thing. Again, COVID-19 vaccines, and it's the story, the classic story of the hare and the tortoise, with the COVID racing on ahead, and we are hoping that the slow and steady vaccine will win the race. So where are we? I spoke about the rollout from vaccine with January 11th, when MDHHS announced that all these other people, including the people 65 and older, first responders, police, K-12 educators, would all be eligible for vaccine. And the MDHHS goal is that 70% of people over the age of 16 should be vaccinated by the end of 2021. But the vaccine rollout has been clunky, and it's been clunky to say the least, and that's being very kind. If you look at this, by the time you see anybody who's age 16 to 64 not covered above in all of these factors is expected to get the vaccine is in late July, early August timeframe. I just want to speak to some of these numbers, and I want to come back to the vaccine distribution in Livingston County in particular. So vaccines, overall, over 70 million people have had at least one dose of vaccine, which is really heartening. And where are we in Michigan? So we've given 2 million doses of vaccine in Michigan, which is huge. And when you look at Michigan figures, 11% of our population in Michigan has been vaccinated with at least one dose of vaccine. So that's pretty huge. We're actually leading the country. I can tell you that we are about the 16th in terms of the number of doses given, a number of people that have received vaccine. And when you look at the doses given, we're so efficient that we're 4th in the country in terms of efficiency of distribution of doses. 4th in the country. So that is, and we are seeing so many challenges. I just invite you to think of what the rest of the country is seeing, probably much worse than us. So what are the challenges? The biggest single challenge has been supply, and supply. The process of how the Michigan Department of Health and Human Services has distributed vaccine remains not so transparent, and they are using different indices, one called the Social Vulnerability Index, to determine which counties should receive more vaccines more than others. Now, that's not a bad thing, because their goal here is pretty noble in assuring that people with who are socially vulnerable, low income, people of color, etc., have more access to vaccine to make sure that these groups are not left behind in this race. But unfortunately for Livingston County, our social vulnerability index is not that low, not that high, because we have pretty good per capita incomes. So we fall last in Michigan in terms of vaccine receipt. But also we've seen recently that we've been receiving even a lower allocation than our SVI would suggest. So for example, we should have, based on just those sheer numbers, received a lot more vaccine on a weekly basis than we have been getting. And so we have been receiving such minimalistic amounts of vaccine that we are among the lowest in the state of Michigan. And so we are appealing at multiple levels to try and correct this, to have more vaccine allocated to our county. The second thing is there is some vaccine hesitancy, although I think people are getting more comfortable now. But if there's any other questions about vaccine hesitancy, side effects, etc., I'm more than happy to help answer, because you guys are the ambassadors that will carry this message to the community and be able to convince people of why it's important to get vaccinated. Variation in providers' capacities, desired doses, and transparency about availability and timing. I can tell you that I didn't know yesterday how many doses of vaccine I would get for this week. And that's a state across Michigan. So if you don't even know how many doses of vaccine you're going to get for a week, imagine trying to set up a clinic and having to schedule people who are going to show up for vaccine, and you don't even know if you're going to have vaccine to give them. We have had weeks where we had to cancel people because we didn't have vaccine. We've had other weeks where we borrowed from Livingston County Health Department to make up our shortfall so that we have enough vaccine to give. And it's all kinds of horse trading that happens behind the scenes to try and make it as seamless for the public. So I know that there's a lot of consternation in the public about availability of vaccines, but I can tell you that the Livingston County Health Department is doing as wonderful a job as it can. We are so closely connected with them, and we work so closely together to make sure that we reach as much of the vulnerable communities as we can. How do we take on different groups so we don't cross paths and, so that we can actually have an additive and synergistic impact as opposed to, crossing each other. So we are in constant contact and doing the very best we can, but it all actually comes down to supply. And we would just say, please be patient. One other thing for this group to know is that we hear on the grapevine that Michigan Department of Health and Human Services and the state of Michigan is going to announce on March 1st that vaccine is, the group is going to be open to those 60 and up. Now, this is going to cause huge consternation. We have thousands and thousands of those 65 and up who are still not vaccinated. And now you're going to add tens of thousands of those 60 and up. So you're going to have, all of you are going to hear about a lot of people who are frustrated in our communities about inability to get in and get vaccine. So I think it's a little too early, and we've given feedback as a system, as a community, as a state. Every health department, hospital, clinic feels the same way, that it's a little too early to do this until we've made inroads into the 65 and up population. But the decision is not ours to make. So I just want to share that with this group, with knowing that you're going to hear your constituents having these concerns, and unfortunately, not much can be done to allay them. it spreads extremely efficiently from person to person. So compared to the previous strain that we had, this particular one transmits from person to person with 70% more efficacy. So it's scary. And we know it's all over in Washtenaw, and we also know that it is seen in over 20 counties in Michigan. And the anticipation is that we're going to have this be the predominant strain by mid to end of March. So this is important for us to know. And it's important that we get those vaccine numbers and take this respite that we have right now to get more people immune. So we are really praying for vaccine. So here are some of the submitted questions that I have, and I'm going to take some of these. I think the seafood allergies, I think I already addressed. Vaccine available for the rest of the public, I think I addressed that too. Why are hospitals vaccinating non-critical staff with no patient contact? Don't they fall into another phase? So let me talk you through a little bit of that, because I know this is also causing consternation. So several of our non-patient facing staff in the hospitals still have extensive responsibilities facing patient families when they come in. So one big example is really our cafeteria workers, for example. They're not, facing patients, but the patients' families are going to stop in there. These are the patients that are sick. They're coming in, their families are coming in, there are visitors. And so in any number, and I could take lots of examples of people that may not at first blush appear to be, say an infectious disease physician going into a COVID room, but they share critical responsibilities that requires them to be in a place where they either get exposed or expose others. And so that's the reason that MDHHS has deemed that hospital employees would fall in the 1A category. But we did move them in categories of 1A1, 1A2, 1A3, etc., to vaccinate them in order of how significant their exposures are. Has my family been vaccinated? So I will tell you that I have parents who are ages 87 and 81 respectively who live in my household. And yes, they got vaccinated because as soon as they were eligible and able to get a spot on the vaccine list, that was the first thing that I did. Some of my other family members are not yet eligible for vaccine and have not been vaccinated, but I can tell you that as soon as they become eligible, they will be on the list to wait their turn to get the vaccine. But yes, so those in my household who are eligible have absolutely received vaccine. Are there any other questions? So I'll stop at this time and I will, oh no, there's more questions, I'm sorry. As a hospice worker in facilities overloaded with COVID, why am I not able to get vaccinated? So I will tell you that a hospice worker or working in facilities loaded with COVID is what we would consider 1A. We have been working extremely closely with the Livingston County Health Department to send out emails to everybody with 1A. Now, at this point in time, I can tell you that Livingston County Health Department has received messaging from MDHHS that of all the vaccines that are allocated currently, 75% have to be used in those 65 and older, and 25% is reserved for others. So they're working with us to help get 1A people vaccinated. We are doing our very best reaching out to everybody. But, as you can imagine, sometimes when we've sent links out for scheduling software to people that are in 1A have shared it with their friends and families, and appointments are gone in 10 minutes and may not get to everybody. So these are the snafus and snags that we have completely no way of being able to control. We can't police every single minute of what we do. So we're trying our best. And what I would say is, Hannah and Jacqueline can get you information, but we have an active, we are collecting names and phone numbers and addresses of people in the 1A category who wish to be vaccinated, and we're making separate arrangements for them to get vaccinated immediately. So if you are a hospice worker who's seeing patients firsthand, you are in the 1A category. So please contact our staff and we will work to get you in separately. I'm trying to schedule my COVID shot. I've heard you shouldn't receive any other shot 2 weeks prior or 2 weeks after. Is that true? Should I cancel my pneumonia vaccine? Absolutely true. You should not be receiving any vaccines for at least a couple weeks. So I would say that 2 to 3 weeks before your first shot and 2 to 3 weeks after your second shot, in that whole entire period, you should receive no other vaccine. So please cancel your COVID shot. If that is, excuse me, I'm sorry, I misspoke badly. Please cancel your pneumonia shot in order to receive your COVID vaccine. I work in manufacturing with multiple locations in Livingston. What's the time frame as to when it'll be available to us? I truly wish I had a crystal ball to tell you. I have no idea because, again, I don't even know how much vaccine I'm getting on a weekly basis, much less when that vaccine, it's a little drip right now, the pipeline. I don't know when that faucet is going to be open full out. If I could, as an infectious disease physician, I would want every one of us that wishes to receive vaccine to receive it at this moment, because that is how we're going to get to the end of this tunnel. So I'm totally supportive of vaccination. I don't know. How does the COVID shot vaccine differ from the effectiveness of the flu shot, and how are they manufactured? So I think I spoke to you about the effectiveness piece, and the manufacture piece. Again, it's completely different science in terms of, it's an inactivated virus for the flu shot and a piece of the virus. And in this one, I explained the mRNA and the adenovirus to you. Why are the variants easier to catch, and what can I do to prevent it? So I told you that the variant is about 70% more transmissible. And the reason that it's more transmissible is that the spike protein, those little red things on the surface of the spherical virus, have mutated. And when we all are exposed to COVID, we have receptors called ACE receptors that are in our respiratory system, eyes, etc., to which COVID attaches. The way that the spike protein mutates, it just attaches much more efficiently than the other virus did. And that's why it's more transmissible, because it just attaches so much better, which is really bad for us. What can you do to prevent it at this point in time? Really, masking. And I'm sure that most of you have seen that mandate about double masking from the CDC. And I'm sure that if you haven't already asked me in the next slide, that is a question that I know a lot of people will have. So what that double masking really is about is to say that when you wear a surgical mask, the sides remain a little bit open for those of you that have used the surgical mask. And that still acts as an avenue for which the particles can actually enter, both as, enter for you, and as you're breathing, exit from that site. So what the CDC did is they conducted a number of studies where they did a few different techniques. So number one was they took the same surgical mask and tied a knot on the ear loop to make it just sit flush and tighter on the side of the face. That was one strategy. And the second strategy was they used a surgical mask and they used a cloth mask on top of it to again, make it sit flush as a secondary mask. And in both of those cases, they kind of had, transmission of particles in two dummies within that 6 feet or even closer between two people that were masked like that, to say, how does transmission efficacy vary? And it showed a 90+% reduction in transmission when either of those strategies was employed. So what does that mean for you? What can you do better? Maybe if you have a loose fitting mask, you might want to make sure that you tie a double knot on the ear loop to make it tighter around your ear so that it sits flush. Or you can use a second, like a surgical mask with a second cloth mask on top of it to make it sit flush. And that is what I think would give you the greatest deal of protection. And of course, vaccination when it is available. If lower income workers depend on a job for their family survival, how should we incentivize workers to stay home and sick instead of going to work and infecting others? And I know that this is a problem that tears at my heart. And it's a problem for how we as a society, what we can do and what we can't do to prevent this. I wish I had a great answer for you, other than to say that, I honestly don't know. If the whole plant were shut down, it doesn't help you that much to go into work, because you may not have a plant to go into in a week or two. So other than that, I don't have a whole lot of ideas, and I would look to this leadership group to perhaps come up with some ideas of how to address that. Why aren't more effective treatments being used as a first line of defense against someone getting sicker and going to the hospital? That's a great question. So recently, some of you may have read about the monoclonal antibodies and how you can give monoclonal antibodies to someone who has COVID early to prevent them from getting hospitalized. Well, I just want to walk this group through. Am I okay on time? I just want to make sure. I know there's more questions, but since we are in the Q&A section, I thought I'd just address all of these. So the monoclonal antibodies are highly specific in terms of how you can give monoclonal antibodies to people. So they have to be people who have had COVID, who have had COVID symptoms for less than a week or even 5-6 days, really. The earlier, the better. They have to have some symptoms and some risk factors, but not enough symptoms to be hospitalized. So you see, when I start putting on each of these one over the other, you see how difficult it is to cherry pick patients who are candidates for receiving this. Once you are picked as a candidate fitting all of these criteria, you have to receive a 1-hour infusion of a monoclonal antibody that does have a possibility of anaphylactic reaction. So it has to be given in a monitored setting, and somebody has to watch you for an hour after you get it. So we have taken the extraordinary step of making this available in our ERs. And once a patient enters the ER to have an evaluation, have the testing, have everything, and then the drug infused and you watched, it's a 5 to 6 hour process. We are doing this in our ERs at Livingston and Brighton. But what we are exploring is some innovative techniques where other counties have partnered with their EMS workers to go to the homes of people that have COVID and meet these risk factors and administer these medications in the homes of people rather than bringing them into the ER. And these are EMS workers, so they are about as trained as you can get for observation and treatment of an anaphylactic reaction should it occur. So I can tell you that the hospital is beginning work on partnering with our wonderful EMS services here. And there's more to come on that. This isn't yet ready for prime time, but we understand the importance of this and we are working closely to try and do all of these things. But honestly, I'm going to throw it back a little bit on the community, right? So why aren't more effective treatments being used as a first line of defense? The most effective treatment as a first line of defense is masking, social distancing, and hand hygiene. So I would throw it back on the community to say, why aren't more effective techniques being used as a first line of defense unless against someone getting sicker and going into the hospital? That is a question I would pose back to each and every one of you. And I think that is where we as a community need to take a step back and say, what can we do together? What are some of the long-term after effects of COVID-19 infections you've seen? So all of you know that this whole phenomenon of the COVID long hauler is beginning to emerge. It's substantive. It is truly, truly substantive. We are beginning to understand that up to 40% of people that have COVID develop long-term complications after COVID. This includes everything from chronic fatigue syndrome, where you have people that were running 10Ks, 5Ks every day, and were healthy, active people who can't get out of bed and be up for an hour or two. I can tell you physicians who have been unable to come back to practice because they just haven't been able to sit up and get up and come to work for more than an hour at a time. People have respiratory issues with shortness of breath. They have inability to maintain any significant levels of exercise. They have chest pain. I can tell you that one of my colleagues in the hospital that I was speaking to yesterday, who had COVID back in December, still is having ongoing chest pains and shortness of breath, and actually had to take a day off of work because that individual could not come in due to these debilitating symptoms. There's neurocognitive effects where people lose memory, concentration. They don't have it's almost like having new onset ADHD. You're not able to focus and do the things that you were able to do. And we're also beginning to realize the after effects on the cardiac system, where in a German study, when they looked at 100 people that had COVID, most of whom had mild enough COVID that they didn't need to go into the hospital, over 70% of people, over 70% of people in that study had effect of cardiac damage on a cardiac MRI. So, when people ask me and say to me, are you going to promise me that these vaccines are safe in 2 years? I tell them, I don't have a crystal ball. I wish I did. I can tell you that the science suggests that they are, but I can tell you without a crystal ball that I see what happens. And when you're saying that 40% of people with COVID develop these effects, right? Neurocognitive, heart issues, breathing issues, inability to get up and resume normal levels of activity. I don't know, but you could say, am I going to get hit by a car every time I cross the freeway? No, you're probably not. But yeah, you're certainly at high risk. So if you want to think about the risk of the vaccine on the one hand and the risk of COVID long-term symptoms on the other, I think it makes great sense to go with the vaccine, which is definitely our safer alternative. And that ends the Q&A list that was provided. But if you guys have any additional questions, I'm happy to take them.
Thanks, Doc. We really appreciate it. You did a great job answering the questions that were provided ahead of time. Thank you for the great presentation. We do have About 5 minutes left. There are some questions in the Q&A. Some of these are folks that are asking kind of specific to them. They have underlying issues, and I'm going to make it just a general question for those folks. I think obviously we don't know their kind of what's going on with them. I mean, my gut instinct would be to maybe perhaps they need to contact their physician, but do you have any advice for those folks that have underlying issues or have had surgeries or weakened immune systems or, issues with that, what course of action they would take with the vaccination?
Yeah. So by and large, I would say that vaccination is considered to be the way to go for the majority of people. I would say that truly there's almost few, if any, contraindications. In fact, I think, there are specific issues if you're pregnant, lactating, etc., that you really need to consider. But in healthcare workers where the risk is even greater than the benefit, the American College of Obstetricians and Gynecologists have actually come out and said, if your risk is that high, you may be better off getting the vaccine than not. So even in those kind of, high risk priority groups, that's kind of the guidance that's given. But I think, by and large, for the vast majority, I think that vaccines are safe, but for individual conditions, I really state that you should talk to your physician to make certain that that's the right modality for you to pursue. There are certain specific things that it would make sense for you to speak to your physicians, and particularly for others that are pregnant in the community and lactating, you really have to weigh your risk and benefit of exposure versus not before you decide. But I can tell you that the data is actively being collected.
Thank you. Appreciate it. So someone mentioned that yesterday, something about the state announced major updates to the vaccine strategy, providers with specific plans to remove barriers to access across the state, with those allowed to request vaccines for people age 60 and up. So I guess the question is, will St. Joe's be able to vaccinate those in need, ages 60 to 65, due to these various health reasons?
So I can tell you that it goes back to that same thing I told you. It's very nice for the state to make major vaccine updates, but if you don't give me vaccine, there's not a whole lot I can do about it. So as I told you, this is going to cause a lot of consternation when people 65 and up, people 75 and up have still not been vaccinated. And so I applaud the thought behind it, because I think it comes from a good place of wanting to reach out to more in society. And, my infectious disease heart wants to do the same. So I applaud the thought behind it, but it's not operationalized. So St. Joe's is partnering with IHA, which is our physician arm, and with the health department. And we're having IHA, our physician arm, that has Moderna vaccinating sites in Howell, and they're trying to open a couple different sites to take over the business of vaccinating. So we hope to provide vaccine to as many people as we possibly can. I can tell you with great pride that we have not allowed a single dose of vaccine to be wasted. Now, let me just walk you through what that means. So once a vial of Moderna is opened, we don't know if you're going to get 10 doses or if you're going to get 11. Sometimes we get 11, sometimes we get 10. So sometimes somebody no-shows, or sometimes, they just weren't able to get there for whatever reason. So we have extra doses. Sometimes we can get more doses from the vial than we anticipated. We don't want to book out 11 doses per vial. But remember also that if we have 6 people, we can't just open a vial, because we have to have at least 10 to open that vial, because we would not want to waste those additional 4 doses. So when I begin to tell you the challenges, beyond the challenges of getting vaccine, the challenges of the logistics of handling a day-to-day vaccine clinic is just tremendous. But my group of individuals who's worked tirelessly at Livingston Hospital, I can only say hats off. I feel so privileged to be part of this team. They have worked tirelessly from 6:30 a.m. till 8:30 at night to be able to make sure that not one dose of vaccine between December 23rd and today has been wasted. We have gotten vaccine into every arm that we can without wasting it. And that is our philosophy, to continue doing exactly that. The more IHA has the infrastructure to vaccinate thousands of people a day. Right now, they're lucky if they can do 400 a week. So to answer your question, will we in the St. Joe's system partnering with IHIH is our directly owned subsidiary. So they're us. So will we continue to vaccinate? Absolutely. We're here for our community, and absolutely we will get every dose of that vaccine into every arm in the community that we can. But we have to have vaccine.
Thank you. Appreciate it. We are running really tight on time. It is 1 o'clock. There are several more questions coming in. I guess my recommendation would be to those that you did not get your questions answered, please feel free to email me at Katie, Katie at heartlandchamber.org, and I can pass those along to the marketing team at St. Joe's, and hopefully we can facilitate that. I hope that's okay, Hannah, that I volunteered you.
Yep, absolutely.
May I take
Guys,
1 minute to answer 2 questions on your chat that I'm seeing?
Okay, perfect.
That I think are so important that they probably should bear talking about. The first is there were a couple of things about fertility issues, and I know that that's something that's been on different social media sites and on the news about this impacting fertility. Very briefly, without going into the science, and I'm happy to discuss it with whomever wishes to, that has been debunked beyond any scientific reason, that there is absolutely no credibility to the vaccine affecting fertility issues. Let me just say that the spike protein antibodies you produce with a natural infection, so this means that every single person that has had COVID is infertile then, which is not the case and not true. So there is no truth to this at all. So I wouldn't allow that to be anything that would stop you from, considering the vaccine. And the other thing is a medical exemption for wearing a mask. Honestly, I have extremely mixed feelings about that, because there are, and those are people that have, significant breathing issues, like severe asthmatic attacks. But by that, I don't mean people who have an underlying condition of asthma. It's when you're having an asthmatic attack that you can't be wearing the mask. But otherwise, I would think that, most people, if not all people, are completely able from a medical standpoint to wear a mask. So those are a couple of the questions that showed up that I wanted to take a moment to go over.
Thanks, Doc. We really appreciate that. I know you kind of were looking through there, trying to get through those as quick as we can. We are a little bit over time. I do want to be respectful, and I want to have time to say thank you to the team today, the Alliance, St. Joe's, Blue Cross Blue Shield Network, and especially you, Dr. Mougdal, for being so wonderful and thorough. So we really appreciate your time today and helping reach the information into our community.
Thank you all for having me, and thank you for taking the time to listen through this. So I appreciate it.
Thank you so much. I hope you all have a great day and don't get buried in the snow. Bye, everyone.